Ladies and gentlemen, please continue to stand by. Your webinar will begin shortly. Once again, we thank you for your participation and we ask that you please continue to stand by. Ladies and gentlemen, thank you for standing by. Welcome to the Heart Health in Baltimore, the Role and Benefits of Community Health Workers webinar. During the presentation, all participants will be in a listen-only mode. If you would like to ask a question during the presentation, please use the chat feature located in the lower left corner of your screen. As a reminder, this conference is being recorded Wednesday, August 14, 2013. I would now like to turn the conference over to Laura Fox. Please go ahead.
Thank you, and good afternoon, everyone. My name is Laura Fox, and I am the Director of the Office of Chronic Disease Prevention at the Baltimore City Health Department. And I wanted to welcome everyone to the Health Department's webinar, Heart Health in Baltimore, the Role and Benefits of Community Health Workers. We have some very exciting presentations ahead, and we are lucky to be joined by experienced speakers who are all leaders in addressing heart health and health disparities. Please feel free to type your questions into the box as they come up, and we will make sure to have time at the end of the presentations to answer any of your questions. I am now going to, in a few minutes, introduce our speakers. But before I do, I just want to spend a little bit of time talking about Healthy Baltimore 2015. Decreasing premature deaths due to cardiovascular disease is a priority of the Health Department. The work focusing on community health workers aligns with Healthy Baltimore 2015, the city's health policy agenda. Healthy Baltimore outlines 10 actionable areas for change. The role of chronic disease community health workers play directly targets the priority areas 1 and 4 of Healthy Baltimore, one being promoting access to quality health care for all, and the fourth being promoting heart health. please feel free to go to our website, www.baltimorehealth.org, and download your own copy of Healthy Baltimore 2015. I am now going to briefly introduce each one of our speakers. They all have such great experiences that I could spend the whole webinar discussing their accomplishments, so I'm just going to highlight a few points on each one of them. Dr. Yvonne Bronner is a professor and the founding director of the MPH-DRPH program at Morgan State University. Dr. Bronner was recently appointed to a 3-year term on the McDonald's Global Advisory Council and a 2-year term on the Chartwell's Child Nutrition Advisory Council. Dr. Bronner's research interests include the role of fathers in breastfeeding promotion among African American families, the epidemiological investigation of American dietary knowledge, attitudes, beliefs, and practices, the nutritional assessment of school children, including internal and external environmental factors, and the role and appropriate utilization of community health workers. As you see, Dr. Bronner has a wide variety of experience and is a great asset on this presentation. Dr. Michelle Gordine is a pediatrician and health policy specialist whose work focuses on addressing the cultural and social forces that contribute to health inequities. As an author and speaker, she seeks to empower individuals to make better health choices for themselves, their families, and communities. Her book, Reclaiming Our Health, A Guide to African American Wellness, reveals the unique cultural and environmental factors that influence African American health and provides motivational and practical steps for the readers to follow and live longer, healthier lives. And we're really looking forward to her presentation today. Ms. Donna Jacobs is the Senior Vice President for the Government and Regulatory Affairs at the University of Maryland Medical System. She is responsible for healthcare policy development, regulatory concerns, and implementation of strategies and practices resulting from policy changes for the University of Maryland Medical System's 12 hospital network. She also oversees the University of Maryland Medical System's efforts, strategic community health initiative, and community benefits reporting for the state and federal level. And it was Ms. Jacobs' recommendation that led to the community health worker training that we'll be talking about later in this presentation. And last but not least, I would like to introduce Ms. DeJuan Monroe. Ms. Monroe was recently appointed Program Coordinator of the Community Health Workers Initiative with the Institute for Public Health Innovation. Ms. Monroe started her career as a community health worker and worked her way up to community health outreach advocate and consultant. She has worked with organizations such as Baltimore Healthy Start, the International Society of Hypertension in Blacks, Grace Outreach Development Center, Johns Hopkins University, and Common Health Action, providing outreach development, workforce training, focus group facilitation, and research program experience in Maryland and Washington, D.C. Now, not only is Ms. Monroe a presenter on this webinar, but for the upcoming Community Health Workers Training, she is also the professor of those. So I want to thank everyone for joining us on this webinar and to all of our speakers for their contributions to improving heart health in Baltimore. I will now turn it over to Dr. Michelle Gordine.
Thank you, Laura, and good afternoon, everyone. It's my pleasure to present very briefly on heart health and heart disease in Baltimore, new day, new strategies. What I want to do in the time that I have is provide an overview of heart disease, including a discussion of the risk factors, a look at heart disease in Baltimore, the disparities and inequities that result from that, and then leading into the next presentations, which are going to provide us with some new strategies and new solutions. So I'll get started. So what is heart disease? We use that term a lot, and it's sort of a generic term, and it actually refers to several types of diseases of the heart and the blood vessels. These diseases commonly begin as hardening of the arteries, also known as atherosclerosis, and commonly end in heart attack or stroke, which are the two most commonly discussed types of heart disease. This slide provides a diagram of what atherosclerosis or hardening of the arteries actually looks like. On the left-hand side, you can see a normal blood vessel, and on the right-hand side, you can see a blood vessel that has become hardened by the accumulation of fat and cholesterol, otherwise known as plaque, inside the blood vessel. You also see on the right-hand side a blood clot that has formed inside the vessel, causing a diminished flow of blood and a diminished supply of oxygen to vital organs. Heart disease, again, is caused by an accumulation of those substances inside the blood vessel, and ultimately the blood vessels can become blocked. This blockage of the vessels, as I stated before, hampers blood flow, and depending on the location of the vessels, the type of heart disease will be determined. If the blood vessels are blocked that supply blood flow and oxygen to the heart, this results in a heart attack. If that blockage occurs in the brain, this results in a stroke. I wanted to dispel a couple of common myths about heart disease. First of all, heart disease is not just a man's disease. There are about 500,000 deaths in the United States each year from heart disease. It is the leading cause of death in the United States. Half of those deaths, however, are in women. Next, heart disease is not just an old person's disease. In the year 2009, 150,000 people under the age of 65 died from heart disease. These are some of the risk factors that increase your risk for developing heart disease. Some of them we can control and some of them we can't. The non-controllable factors include age, family history, and race. The controllable risk factors include smoking, high cholesterol, high blood pressure, and obesity, which is obviously related to diet and exercise. The reason that the controllable risk factors are so important is that there are interventions that we can undertake to reduce those risk factors and thereby reduce the risk of individuals developing heart disease. This slide demonstrates heart disease disparities in the United States. We all know that there are certain racial and ethnic groups that are at higher risk for developing heart disease across the United States. This is also true in the state of Maryland and in the city of Baltimore. What I want you to pay attention to is the middle purple bar, which demonstrates that African Americans are 30% more likely to die from heart disease than whites. Now let's talk a little bit about Baltimore City. We just saw on the previous slide that African Americans are more likely to die from heart disease. Baltimore City is a city, as we all know, that is predominantly African American, with 64% of the population identifying themselves in that category. Heart disease is also related to educational status. People who have a less than high school education are more likely to develop heart disease. 29% of individuals in the city fall into that category. Employment and household income are also associated with heart disease because, as you can imagine, depending on the type of employment that you have and the median household income that you have greater access to health care or health insurance based on those two factors. 34% of individuals in the city are not working, and the median household income is $30,000, which is lower than the state average. 1 in every 4 deaths in Baltimore City is due to heart disease. It is the leading cause of death in Baltimore City. And this slide demonstrates a 20-year disparity in life expectancy. Largely contributory factor is the presence of heart disease and the prevalence of heart disease in Baltimore City. The thing to notice in this slide is that the darker colors represent the lower life expectancy, primarily concentrated in West Baltimore and on the east side. The light pink colors indicate the higher life expectancy, which would be in the upper left-hand corner of that graphic. The distance between the highest life expectancy and the lowest life expectancy in terms of miles in Baltimore City is approximately 5 miles. So within a 5-mile span, you have a 20-year disparity in life expectancy. The next slide will begin to demonstrate why there is such a difference. We saw in the previous slide where we talked about the risk factors that diet and exercise are very important in terms of increasing or decreasing the risk of developing heart disease. Beyond the desire to eat better or to exercise more, it helps to live in a community that promotes those types of activities. However, we all know that some communities promote excessive food consumption and physical inactivity. You see on the left-hand corner of the slide a neighborhood with very heavy traffic patterns. On the right-hand corner of the slide, overgrown and broken sidewalks, neither of which help facilitate safe and affordable physical activity. And in the center of the slide, a picture of a corner store, which, as we know, has a very limited selection, oftentimes, of healthy foods, and often those foods can be very expensive. This correlates to what is happening in the previous slide where we saw the lower life expectancy in the darker colors, that oftentimes in those communities you have a lack of resources that promote healthy eating and active living. The bottom line is that heart disease is preventable. It is important to have great access to health care so that heart disease can be diagnosed and treated earlier. But what's more important is on the following slide. Getting to the root cause of heart disease. As you notice, heart disease is only one of several chronic conditions, including diabetes, cancer, chronic lung disease, etc., that have very similar root causes. The good news is that if we get at these root causes of physical inactivity, smoking, and unhealthy diets and help to make changes, then we can not only prevent heart disease, but several other of our leading causes of death here in Baltimore City. It's time for new strategies for a healthier Baltimore, which include changing our environment, making sure that every environment provides every citizen with an equal opportunity to be healthy, educating individuals on what we all need to do in order to remain healthy, therefore empowering people to take charge of their health. And with that, I will conclude my presentation, and thank you for your attention.
Hello, my name is Yvonne Bronner, and I'm very pleased to follow what Dr. Gordine has said regarding the need to improve our health education, our physical activity, and our diet, and community health workers are very important in this. Next. I will begin by defining community health workers, give a brief history of how they've been used over time, speak about their unique status, give some examples of how they're currently being used, speak about cost savings when we use community health workers, and end by speaking regarding their benefits. Next. Community health workers have many definitions, and of course the Association of Public Health has a very detailed definition. The one I'm using today comes from the Community Health Worker National Workforce Study, and it says that community health workers are lay members of communities who either work for pay or as volunteers in association with the local healthcare systems in both urban and rural environments, and usually share ethnicity, language, socioeconomic status, and life experiences with the community member they serve. And almost every word in this definition is important, and hopefully you will hear examples of it as I move through the presentation. Next. In terms of the history of community health workers, ever since the beginning of man, there have been people who worked within communities to help them stay healthy. And going all the way back to the hunters and gatherers and over the hundreds of years of the evolution of man. However, in the last 150 years, other trained and licensed practitioners have become a lot more a part of our healthcare delivery system, and hence this has in some cases marginalized the formal use of community health workers. However, the informal use of community health workers never stopped, especially in developing countries and in underserved areas of the United States, though the role nor the contributions of these workers were appropriately acknowledged. Next. And hence there is a need for community health workers. And that need is due to the following. We're having a tremendous change in the U.S. population. I think all of us are aware of the fact that our population is growing older and much more diverse. And at the same time, there is an increase in the complexity of our healthcare delivery system. We have a shortage of primary care providers. There are more people with the various chronic diseases that Dr. Gordine alluded to. And in the same breath, we have rising health care costs and hence a growing number of people who are uninsured and would therefore having limited access to the health care system. And community health workers can help in all of these ways. Next. So the challenge that we face is one that we believe community health workers are particularly well positioned to help us with. And this is one way that we can help the U.S. population have a higher quality of health in all the ways mentioned earlier through better diet and physical activity. Next. So who are community health workers? They are importantly members of a community. Oftentimes they're chosen by community members or organizations because they have been already doing the kinds of things that we want them to do. People recognize this and they then become trained and potentially members of the community health worker workforce. Their role is to provide primary or basic health care, health and medical care to their communities. Next. Now, community health workers are known by several names, and this can often be confusing. They are sometimes called lay health providers, community health aides, promotores, community health advisors, etc. Next. When we want to get a snapshot of what this workforce looks like, I went to the National Workforce Study, and we found that in 2005 there were approximately 120,000 people so designated as community health workers. They were working in many settings, such as hospitals, community health centers, health departments as examples. And their tasks were also many. They were they performed patient registration, did translation, performed health education, and assisted with basic health assessments. And these community health workers have varying levels of training. Most of them have a high school education. Many of them have 4 years of college. Some have some college, and very few have a high school education only. Next. In terms of the effectiveness of community health workers from the literature, we find that there's strong evidence to support the fact that community health workers are associated with increased access to care. In terms of measuring their outcome, increased health knowledge and behavioral change has a weaker evidence base but is a secure base. When we look at cost effectiveness, however, that is whether we can actually say outcomes are attributable to the efforts of our community health worker, the evidence is weak, but that's not probably due to the community health worker, but to the methods that we've used, and those assessments are in the field as we speak. But in terms of cost savings, we have several examples of positive changes that can be associated with community health workers. Next. One example comes from Denver, where community health workers were documented to save $2.28 for every dollar invested. And right here in Baltimore, we had a study of community health workers in a diabetes intervention and found 38% drop in emergency room visits, 30% drop in hospitalizations, and this was associated with $80 to $1,000 per year savings per community health worker. This is significant. And in Kentucky, 39 community health workers visited 58 rural communities, and for every $1 invested, they were able to raise or secure $15 to $20 in free health services for this underserved population. Clearly a significant input. Next. So what is the role of the community health workers? First of all, they provide cultural mediation between communities and health and human service systems. And this is mainly because they often come from the communities. They've already figured out how to moderate and mediate these systems, and hence they're in a very good position to help others. They provide informal counseling and social support. provide culturally appropriate health education, advocate for individual and community needs. They ensure that people obtain necessary services. They build individual and community capacity, and this is very important because they live in those communities, they're trained, and hence that community capacity is built. Provide basic screening such as immunizations. Next. Community health workers can be most effective, however, when communities are engaged in improving their own health. And this is why building community capacity is so important. The community health workers who live in those communities can help communities identify needs and then advocate for those needs. They work most effectively when they are in partnership with other frontline health workers and are anchored in the primary health care delivery system. Next. Are community health worker credentials needed? This is a discussion that's in progress right now. Next. So credentials are being discussed positively because they may help integrate community health workers into the healthcare system, raise the visibility of the community health worker role, allow community health workers to be paid and obtain higher pay. Now, some people believe, though, that if we have credentials, some good community health workers may not be able to meet the standard and hence be forced out of the community health worker workforce. And, of course, this is something that we need to pay attention to as we move forward. Next. In terms of community health worker funding, one of the major problems is that often their funding is short-term. It is related to projects, and these projects are time-limited, and this is a limiting factor in terms of developing this very important workforce. However, it's good to note that 2/3 of community health workers are currently wage earners, while only 1/3 of them are volunteering. And we would certainly look forward to the time when all of them will be wage earners. And an experienced community health worker could expect to earn about $13 an hour, and this is an average figure. Next. Very important is the fact that we now have a community health worker provider code. As of July 2007, the provider taxonomy of the National Uniform Claims Committee has a provider code for community health workers, and this means that the code can be used in fee-for-service claim systems, allowing community health workers to be paid by Medicaid and other insurance providers. Next. Community health workers allow us to win. That is to do better and have better health status in our communities. And I'm going to give a few examples of this. Going back to the 40s and moving forward in China, they successfully combated rising costs of healthcare delivery and the maldistribution of trained health professionals by deploying community health workers. And they were called barefoot doctors back then. Next. In Brazil, they used community health agents in family health care in the 90s, and this resulted in infant mortality dropping from 50 to 29.2 deaths per 1,000 live births. And this is, of course, a very important drop. In Iran, they used community health workers during from 1984 through 2000, and they cut infant mortality in half and increased immunizations from 20 to almost universal status of 95%. And at the same time, they decreased maternal mortality from 140 to 37 per 100,000. All of these are significant changes in the presence of community health workers. Next. All of this has been said to indicate that community health workers have a tremendously important role to play. They are important. And by including community health workers in the healthcare workforce, we are able to take a very important step on the path toward the Healthy People 2020 vision of a society in which all people live long and healthy lives. Thank you.
Good afternoon. This is Donna Jacobs, and I'm so glad to join this important discussion as we move toward enhancing the numbers of community health workers here in Baltimore City. I'm going to try to bring this discussion to a more local level. You've heard a quite expansive and very good history and background here, and now we're going to begin to talk about why community health workers are important in Baltimore and give some precise examples of community health worker programs where they've been used well. So you've heard over the years that community health workers have been utilized in quite a number of programs targeting chronic disease, including cardiovascular disease. HIV is another area that we've not spoken about yet, and infant mortality as well. They've been used extensively in cancer programs and with diabetes. So why do we need community health workers here in Baltimore? The same issues that you've heard Dr. Bronner address pertain here in Baltimore as well, except they are perhaps a little bit intensified. And it's important that we address the health disparities that we know exist here in Baltimore. While many health outcomes have improved nationally and here locally over the last decade or so, significant disparities still exist between different groups. African Americans, as you've heard from Dr. Gourdine, are 30% more likely to die from heart disease than whites, by example. Baltimore City continues, not only in heart disease but in other areas as well, to show poor results on nearly every health indicator, heart disease being one, infant mortality, cancer, stroke, and asthma. While our primary focus here, of course, is heart disease, as you heard a minute ago, and we know it to be responsible for a quarter of all deaths in Baltimore City, it is not the only area that we'll need to focus on moving forward. Accessing health care here, as in other places, can be daunting and is often exceedingly difficult. For residents in Baltimore City, there are quite a number of negative health inequities. That would be systemic, social, political, economic, and environmental practices and policies, as well as many negative social determinants of health, which may include lack of access to healthy foods, lack of housing, adequate housing, inadequate access to health care, primary health care in certain neighborhoods, safety concerns, lack of education, and the like. All of these are at work. Many of these factors make it difficult, if not impossible, to focus on one's health. And if one is able to focus on their health, then you have the compounding factor of the difficulties of breaking through the morass of the healthcare industry. When you take all of these factors and you often just overlay what I'll call plain fear, as many people are fearful of the unknown or fearful of seeking care, you really have the perfect storm, and that's what we have been confronting for a number of years here. So now enter the community health care worker. As you've heard, they're lay people from the community. They know the community. They know their residents. They know the concerns and may have lived them. They know how to access resources through some of the training they may have received, and they are essential and vital to removing many of the barriers that we've talked about and helping people make their health care a priority, help them find care, and then ultimately to help them control their disease. Their successes nationally are really well documented. Dr. Bronner, nationally and internationally, Dr. Bronner has just addressed that. Before we talk about Baltimore, I'm just going to give you a couple more examples of some national programs. I've listed only a few here: Rhode Island program for diabetes, a Florida program to assist pregnant women, a Georgia program on chronic disease. Cancer programs have nationally been very proactive in using community health workers under a number of different titles, and we'll talk about that a little bit in a moment: navigators, outreach workers, promotores, etc., to great avail and great success. I'm listing here for you in alphabetical order only a number of programs that currently use or have used in the past. Some are still existent, some have closed for reasons that you may hear about later. These have all used community health workers under a variety of different titles, and you'll see the kinds of areas that have been addressed: asthma, cancer, diabetes, infant mortality, etc. I'm going to focus a little bit for just a moment or two on a couple of these: the Be More for Healthy Babies program and the Baltimore City Cancer Program. Be More for Healthy Babies uses community health workers, and they describe them as the gateway to care for many in need and the link to healthcare services. Their community health workers play a pivotal role. They partner with community-based organizations, faith-based organizations, and community businesses, as well as healthcare providers. Importantly, the community providers work with the program and identify pregnant women for entry into the program. The objective here is to have healthy babies living beyond the SIDS and infant mortality issues that we often see here in Baltimore. The community partners also help spread the program's messages: safe sleep, smoke-free homes, etc. And they become champions for the program moving forward. So there's a great partnership there that's important. They talk about the existence of the program and the relevance and importance to our community. The Be More for Healthy Babies, for instance, uses barbershops as community partners. They go in once a year, provide a program, and then train the barbers to continue to talk about the success and relevance of the program moving forward. The community health workers are largely responsible. Indeed, most of the referrals come as a result of their work. The CHWs also partner with the pregnant women as their access. So not only do they help them, as their advocates, not only do they help them obtain access to care, but beyond that, they help them overcome additional barriers that are problematic to obtaining and maintaining the best health care for both themselves and their babies. And that may include transportation barriers, getting back and forth to health care, inadequate housing, and they even describe women who need food and have come in without having had a meal all day, and they help them secure what they need. They also take baseline needs and risks assessments, such as mental health needs, dental needs, and identify other comorbidities. The CHWs stay with the moms until the babies are 18 months old. Many of the moms have ultimately become quite empowered and serve on Be More community boards, go on to pursue their GED. They also seek assistance with resume writing and other work search. So the work goes beyond just the health care, but begins to address some of the social determinants that are also problematic. When fully staffed at Be More for Healthy Babies, there are 3 community health workers. They are paraprofessionals, generally with a GED or a high school diploma. And again, they know their community. They've often had the same experience as the moms who they are working with, including some who have had premature births. The ratio for the community health workers is 1 worker to 25 moms. The program touts huge successes, and much of that having been the contributions of the community health workers. There have been major reductions in infant mortality over the years that this program has been in effect. 96% of the moms who have been in this program have had at or near-term births, and there have been no deaths of any infants in the program. And that's contrasted in the year 2011 with 94 deaths across Baltimore of infants before age 1. Additionally, and lastly on this point, I would say that 3 months postpartum, 60% of the moms are receiving the needed mental health services that were identified at the intake. And then the last program that I'll talk about is the Baltimore City Cancer Program. This is part of a statewide effort where Baltimore City is looking to reduce primarily breast cancer, but also looking at oral and cervical cancer screenings for women. They have community health workers identified in 2 capacities. One as the community outreach workers, and these women identify women in the community and bring them into the program. But at the program level, once someone is brought into the clinic and presented with a diagnosis of cancer, there are navigators who help them work through the system, work through insurance issues, and other social and environmental concerns. So they really work toward helping the patient stay focused on health care and getting well and reducing the additional stressors that might otherwise complicate their care. These navigators are largely responsible for an impressive number of women who are participating in clinical trials at the University of Maryland Medical Center which are directed at improving the healthcare outcomes for women in this general population. Indeed, that's tops in the nation. They also help women stay compliant with their appointments and with treatment, and the program has had absolutely stellar results in detecting cancers at a much earlier stage in the community and better health outcomes. Ordinarily, African American women present later with a breast cancer diagnosis or problem and have much poorer results. So in the time that the program has been in existence, for all the screenings, there have been about just over 30,000 screenings and only 6 deaths in that time. So these programs have worked very well. People connect to health care, and then they're guided through the elimination of barriers that might not help them obtain the necessary and the best health care outcomes that they need.
Good afternoon. My name is Dwan Monroe. I am truly excited to be on this webinar as a former community health worker and now program coordinator with the Institute for Public Health and Community Health Worker Initiatives. I will be discussing today in more detail the role and responsibilities and skills that community health workers can bring to all organizations pertaining to dealing with chronic disease management in health and health disparities. I just want to reiterate some things that Dr. Bronner and that Donna have discussed in reference to community health workers. They are designed to improve the access to care, increase knowledge, and prevent disease, and improve select health outcomes for populations, particularly populations that are reflective of the outreach workers themselves. They carefully tailor these outcomes to meet the unique needs of the community. As Dr. Bronner stated before, there are several different fields in how they serve in organizations. As a member of the care delivery team, a care coordinator or manager, definitely health educator, outreach and enrollment agent, and a community and capacity builder and organizer, which is the overall arching importance of the role of community health worker. Not only do they help provide delivery and support of important health care related to chronic disease, they have the capacity to bring the community in a whole environmental state to understand what behavior change in health means. A lot of times programs may utilize community health workers in each individual role, but they're not mutually exclusive. They may fall into different categories and share different roles throughout their programs. More important roles in the community of community health workers are creating more effective linkages between vulnerable populations and the healthcare system, managing care and care transitions for vulnerable populations, making sure that not only that populations or community people have access to insurance, but access to quality care once they receive insurance and are placed into care. Ensuring cultural competence among healthcare professionals serving in vulnerable populations, and providing culturally appropriate health education on topics related to chronic disease prevention, physical activity and nutrition, and cultural competence. So when we talk about cultural competence, community health workers have the ability to be that bridge or navigator to work with not just the community people that they live and work and play with, but also to work with the healthcare system and getting them to understand the cultural aspect of understanding patients that look different from the providers that they're working with. They also advocate for underserved individuals to serve for appropriate services, provide informal counseling, and build community capacity to address these health issues. Community health workers' models of care, issues of liability. There have been several challenges or concerns, particularly with organizations who are not familiar or who have not brought on community health workers yet, in understanding issues of liability with employing and utilizing community health workers. One particular area is when the community health worker is a member of the care delivery model. In this particular model, they provide some direct health care services when it comes to measuring blood pressure and pulse, provide some first aid care, medication counseling, and health screenings, among other basic services. While the community health worker may render limited direct health services and serve in this capacity, it raises some questions about consequences of maybe mistakes or some type of negligence. However, if a volunteer or a paid CHW is negligent, the community health organization or employer may be liable. So this may be of some concern for organizations who are bringing them on, but we will talk about ways to help manage that. Another role and possible concern for liability is the outreach and engagement role. In this model, CHWs conduct intensive home visits to deliver psychosocial support, promote maternal and child health, as discussed from the previous presentations, conduct environmental health and home assessments, and offer one-on-one advice to make referrals. They also help individuals to enroll in government programs. So CHWs that serve an outreach capacity typically receive certain specialized training in order to do this. An implementation consideration when it comes to dealing with liability is CHWs may visit hard-to-reach populations in their homes, and programs may consider acquiring liability insurance prior to employing the CHWs in the model, given that travel and home visits may be required. Additionally, programs should consider to counsel their CHWs to be aware of their surroundings during their travels. For example, most programs counsel their CHWs to discontinue an appointment if they feel uneasy during a home visit. While CHW programs recognize these liability issues, few have formal policies in place. So programs should see whether their state has relevant laws in order to understand the broader context of their activities. Programs should also think about or assess the liabilities when you have community health workers who are driving and you're considering as a part of your program having your outreach workers go with their clients to their appointments. Are they able to be in their vehicles? Is this employer responsible for a CHW who was injured on the job? Or does the employer's liability change if the CHW is paid versus volunteer? These are some considerations when thinking about liability issues in your organizations and bringing on community health workers. Organizations that hire community health workers may consider acquiring malpractice insurance. Programs should educate their community health workers about their scope and practice and responsibilities. So when we talk about education, I want to definitely let you know about the West Baltimore Primary Care Access Collaborative, which will be happening with community health workers. There will be an 80-hour core training beginning on August 19th to August 22nd. The locations will be for the first week at Coppin State College and second week Amesmore United Methodist Church. These trainings will encompass a wide range of the core skills and values of being a community health worker, as well as understanding unique details in reference to heart disease, diabetes, asthma, and other chronic diseases that affect particularly in the West Baltimore community. This core training are for skilled or organizations who provide utilization services through community health workers, and is quite intense throughout the entire week. If there are other community health workers or organizations who want to provide some more less intensive but more detailed and structured trainings that has a more flexible schedule, we are also providing community health worker drop-in trainings beginning September 9th through the 22nd, which will be held on Tuesdays from 6 to 8 and Thursdays from 12 to 2 p.m. This will take the 80-hour intensive core training and somewhat condense it, but still provide enough information for community persons and organizations who are working with community people through churches, through community-based organizations, through community neighborhood associations and senior centers to come in and learn about the unique skills and roles and what community health workers do as a preliminary prerequisite for possibly becoming employed as a community health worker. I am truly excited because I will be one of the main trainers, along with Ms. Linda Scruggs, providing both trainings for this great initiative that is happening in West Baltimore. Thank you.
Thank you. And now I'm just going to spend the last few minutes talking about some of the resources that the Baltimore City Health Department as well as the West Baltimore Care are providing to residents and community health workers in Baltimore City. So first is we have a number of books entitled Community Health Education Methods, A Practical Guide. And this book is here to assist future practitioners in effectively communicating health education messages and positively influencing the norms and behaviors of both individuals and communities. And now we have a number of copies of this book. You all have my email, and feel free to send me an email to get copies of that book. If you need a number of them for many of your staff members, we can arrange a time for us to drop off a packet of books or to come here to the health department as well. Additionally, the health department was able to print a great deal of wonderful information that's been put out by the American Heart Association in terms of sodium reduction, cooking strategies, physical activity. We have a number of these already printed out in color on cardstock that are really great for you to be passing out to members of your community, and this is an additional resources that the health department has. So feel free to contact me for that as well. And lastly, like Dewan said, we are so excited about the community health worker training that's coming up. The intensive one had 20 spots in it, and within 48 hours, actually all 20 spots were filled, and there is currently a waiting list, but you can also still feel free to email Scott Thorpe about that training as well. His email is at the bottom of this slide. And I would really recommend everyone who can send community health workers or residents to the trainings starting the week of September 9th through October 22nd. As Dewan said, she's one of the trainers. It's going to be a really great opportunity and a really great resource for all residents in Baltimore City. And we're really creating a network of trained community health workers throughout the whole city, east, west, north, south. So we're very, very excited about that. Lastly, I would just like to thank all of the speakers and presenters today. Everyone, thank you so much. You did a wonderful job. And to all of the participants for listening in, and we hope that you pass this information along. Again, if you know anyone who wasn't able to make the presentation today, we are happy to pass this along to you. And thank you to the State Department of Health for funding to be able to put on this webinar and to help promote the training and all of the resource materials. Now, it doesn't look like we had any questions at this time. If you have any questions, please type them in. We'll give it about another minute or two, and then if there aren't any questions, we will end the webinar for today. So thank you again to everyone. And my email is at the bottom here, laura.fox@baltimorecity.gov. And again, if you have some questions in terms of signing up for the community health worker training, for the less intensive ones, please email Scott Thorpe at scott_thorpe@bshsi.org. And locations for those trainings in September will be coming out very soon. And I'll make sure to email that to everyone who is on this webinar today. So it looks like we don't have any questions coming in, but if you get home and you decide that you have a question you'd like to address to myself or to any one of our speakers, please feel free to send myself or our speakers an email, and we'll be able to make sure to get back to you. Someone asked, can I get a copy of the slides? Yes, the slides will be posted on the Baltimore City Health Department website in addition with the presentation in fall, so we can make sure to get a copy of that to everyone. So again, thank you everyone for joining us, and we look forward to partnering and working with you in the future. Have a wonderful day.